Cast is now starting. All attendees are in listen-only mode.
Hello. Hello and welcome to our first webinar of 2020, Measuring Senior Wellbeing. Make sure that everything is working here, yes. My name is Chantal Stevens. I'm with the Community Indicators Consortium, and I am particularly thrilled to start the year with this important topic and with two outstanding presenters, Laura Oteling and Emily Mutillo. In most countries, the proportion of older people, those aged 65 and above, has been steadily increasing. It stands at 14% in the US, 15% in Canada, and 16% in Australia, with Japan at the high end of the spectrum with about 30%, almost a third of its population over 65. Projections are that those numbers are expected to climb from 50 million in the US to 83 million by 2050, and similar increases elsewhere. We often look at this issue from the point of view of the labor force and the impact on so-called entitlements, but we don't often consider how this affects the senior themselves. Our two speakers today will help understand some of those issues related to a growing population, how we track those issues to ensure the well-being and quality of life of our older adults. We will first hear from Laura Oteling. She's an epidemiologist with Arundel and the lead author of America's Health Ranking Senior Report. You will hear a lot more about this today. She has an MPH in epidemiology and is pursuing a PhD in epidemiology at the University of Minnesota. Our next speaker, Emily Mutillo, is a research fellow at the Center for Community Solutions, where she focuses on issues that impact older adults, such as an analysis of senior levy funding in Ohio and a need assessment of older adults in Summit County. She holds a Master's of Public Administration from the Cleveland State University. As we listen to our speakers, feel free to enter questions for them. But unless the question requires an immediate clarification, we will answer them at the end of the hour. So now let's turn the screen and the microphone to Laura.
Hello, and thank you for that introduction. Let me just make sure that everyone can see my slide.
Yes, we can. Thank you.
Okay, great. Okay, so I'm going to be talking to you today about a measure of risk of social isolation among seniors. We've done some work on this as part of one of our reports on the health of seniors. And just before I start, I just want to disclose that United Health Foundation funds this work. And so just to get started, I'll give you a background of these population health reports. America's Health Rankings is one of the longest running annual assessments of the nation's health on a state-by-state basis, starting with the annual report in 1990. It's a source for states to track trends in their population's health and for relative rankings of their health. And the senior report is something that we started in 2013. It covers the adult population, ages 65 and older. And like our other reports, it provides a benchmark, simulates action, and highlights disparities. And it's an analysis of 34 different measures related to behavior, health behaviors, community and environmental factors, clinical care, data, and health outcomes. Our model for all of our reports is developed in collaboration with an advisory group of leading public health experts and our data is largely comes from public use data sets. And so this particular measure of risk of social isolation among seniors was something we added in 2018. When we first add something to our report, we add it as a supplemental measure, just meaning it doesn't contribute to our calculation of state's overall health ranking. But this year, we are going to be moving it into the core model and a category for social and economic factors.
Laura, if I can
and just,
very quickly, we can see the
sure.
panel, the control panel on the screens that it's blocking part of the screen, the slides.
Is this help?
Yes, thank you.
Oh, thank you so much. Okay. All right, I'll continue. And so the reason that we added this measure is in recent years, the issue of social isolation and loneliness has garnered increased attention from researchers, policymakers, and the public as societies age. The use of technology increases and concerns about the impact of loneliness on health grow. We felt that social isolation may be more prevalent in older adults and would be important to investigate as the population of seniors continues to increase. Alrighty, let me get back here. So just to begin, let's talk about what is social isolation. Simply, I'll define it as the absence of meaningful social relationships. There are many definitions and varying ways to measure it. We found it important, again, because as adults age, their social roles and network structures change due to such things as retirement, loss of loved ones, and potentially physical and mental health decline. And social isolation has been shown to be associated with increased risk of mortality, poor health status, hypertension, and a bunch of unhealthy health behaviors. So in the creation of this measure, we were informed by a report by the AARP back in 2015. This report laid out kind of a framework for thinking about isolation in adults, older adults, and gave a pretty thorough list of risk and protective factors for adults as it relates to social isolation. So we selected a number of factors that we felt were an objective measure, looking at the risk of social isolation rather than measuring social isolation itself. And so we selected these factors from the American Community Survey. We limited our analysis to adults age 65 and older. And so the following 6 factors are what we include in our index. And those are poverty, living alone, divorced, separated, or widowed, never married, having any disability, and then having an independent living difficulty. So we calculate a standardized index of these 6 factors, and then we rank states based on their overall percentile. So we pick these measures because they're objective, they're available at multiple geographic levels. While we're a state level report, we actually produced county level, tract, and zip code level data for this particular measure. And these measures are updated annually. So this is what the risk of social isolation looks like by state. Our definition that you'll find on our website is percentile of the mean Z-scores for these 6 risk factors. Lighter colors are mean lower risk of isolation. So top 5 states are listed here, and bottom 5 states. Again, the source of this data is American Community Survey 2013 to 2017 estimate. We generally display most of our measures for the senior report by quintile maps. And we also provide just the breakdown of prevalence of each individual factor. And so this is just a summary of, this is based on the 2013 and 2017 data that almost 9% of seniors are living in poverty, 10% were living alone, a large proportion were divorced, separated, or widowed, about less than 5% were never married, 35% had a disability, and 14% had independent living difficulty. So now this is just a snapshot of risk of social isolation by county. So Utah, that was the top ranking state, and then Mississippi was the bottom ranking state. So you can kind of see what it looks like at the county level. 21 of 29 counties in Utah have very low risk of social isolation. San Juan County is that one county in Utah that has the highest risk, followed by Beaver and Carbon counties. And then in Mississippi, 62 of the 83 counties have a very high risk of social isolation. And then there are 4 counties that kind of stand out as having a lower risk of social isolation relative to other counties in the state. These maps can be found on our website under the state summary pages. We also did, like I said, an analysis by census tract and also zip code, which I don't have an image of. And this is kind of a snapshot of the Minneapolis area where I'm located. And this particular visualization is not available on our website. However, census tract and zip code level data can be provided by request. And this is a heat map of the risk of social isolation percentiles, sorry about that, and correlation with the individual factors that make up that index. So you can see that poverty, divorced, separated, or widowed, and to a certain extent disability seem to be more highly correlated with the overall index than living alone and never married. And so of the bottom 10 states with the highest risk of social isolation, 8 of those 10 have a high percentage of seniors with a disability. 7 of those 10 have a high percentage of seniors with an independent living difficulty, and 7 of 10 have a high percentage of seniors living in poverty. And we also did a heat map with what we felt were related health determinants that we also measure in our senior report. So this is a heat map of risk of social isolation, cognitive difficulty, community support, depression, and volunteerism. And cognitive difficulty is most highly correlated. You can see, again, of the bottom 10 states with highest risk of social isolation in the nation, 8 of those 10 have a high percentage of seniors reporting cognitive difficulty. And then of the top 10 states with lowest risk of social isolation in the light blue here, 4 of the 10 have a high percentage of volunteerism. And I've listed the various sources of this data at the bottom of the slide. And then doing this also for what we felt were related health outcomes that we have on our senior report. We have a similar heat map looking at frequent mental distress and high health status. Those are both measures from the Behavioral Risk Factor Surveillance System survey, and then early death rate. And you can see that 8 of the 10 states that have the highest risk of social isolation also have a high percentage of seniors with frequent mental distress. That's pretty highly correlated with the overall index. And 8 of 10 have a low percentage of seniors reporting very good or excellent health status. And 7 of 10 have a high early death rate relative to other states. That's deaths per 100,000 adults aged 65 to 74. So now I just have some thoughts for future development of this particular measure. Some kind of questions for the audience and thoughts for future directions for research and for improving this measure. So just a question to the audience in general is, what can we do to improve upon this measure? One question of interest is, which factors might have the greatest predictive value for social isolation? Currently, the way that we calculate the measure, the z-scores assume that a difference of 1 standard deviation is the same for all variables, which may not accurately reflect their association with social isolation in older adults. Of course, we're only including objective measures based on kind of the structure of our report and data availability. And a potential direction for future research might be also identifying the relative effects of each component, which may be more useful in targeting those that could be modifiable. In addition, there were many risk factors specifically from that AARP report that I referenced earlier, which may be more strongly related to social isolation in this population, which we're not including, and we may be able to include as more data sources are available. We don't provide any type of demographic breakdown, such as by race, ethnicity, gender, or gender identity or sexual orientation, which might be very interesting for this particular measure. And we also don't provide a rural, suburban, or urban analysis. And so those are some areas that we potentially are looking at for the future. So that pretty much wraps up my presentation. I know I'm done a little bit early. So I don't know if we just want to move on to the next one or take some questions now.
Actually, since we have a little bit of time, maybe you can answer the one question that we have specifically to your presentation, wondering if you can explain how independent living difficulty and cognitive difficulty are different from disability in your analysis. And it says, in other words, what is included in disability, for example, vision, hearing, ambulatory, etc.
Okay. So in the disability, let me see if I can maybe go back to so in the disability measure, this includes I think 5 or 6 different disabilities. So vision, hearing, ambulatory. Let me see, I can actually probably pull it up really quickly so I can be fully accurate. So self-care difficulty, ambulatory difficulty. It also includes independent living difficulty, which we also are measuring separately because we felt that was even more relevant for this particular measure. And then, like I said, vision and hearing difficulty.
Thank you.
And I think there was another, I don't know if I fully answered that question. Now, okay, now I see it. Okay.
Yeah,
I think I did answer that. Okay.
Yes. So thank you. Maybe I have one question as well. Is so you focused on social isolation. Can you maybe put that in the context of the other the rest of the data that came out of the findings from your report? Is this the most pressing issue? Is this the one that has the longer term, the more risk on quality of life?
So the way our report is structured is we have different model categories, and they're generally weighted equally. So this particular measure fell into a category of social and environmental factors, or sorry, social and economic factors. And so this is an area we've been trying to build out in our reports, because generally we're fairly heavy on health behaviors and clinical care measures. So it's not necessarily weighted more than other factors, and we aren't making conclusions about whether or not it's associated more with quality of life or mortality or things like that. It's basically we're presenting descriptive statistics, but we do have control a little bit over how many measures we have in each category, and then kind of what we are deeming as important. And so we felt like this measure captured kind of an area that we were missing for senior health. And just for example, let's see, I did have kind of a slide listing all of our measures, which I ended up removing. Okay, so some of the other kind of measures in that general category of social and economic factors are food insecurity, nursing home quality, home delivered meals, I think air pollution is one. And you can, if you go to our website, if you go to americashealthratings.org, you can click on Explore. You can click on Explore Report Data, and then navigate to the Senior Report, and you can look at all of the measures we include, and then the state level data.
Okay. Well, thank you. We do have one more question. Maybe we'll take that one too before passing it down to Emily. Unless, did you want to add something? No. So did you do an overlay with any portion of the data with areas where actual experience of social isolation were reported?
We have not. I think I would be interested in finding a data source for that where we could do that type of analysis. I guess I'm not aware right now of data on kind of perceived or subjective measures of social isolation by state or by county.
Okay.
Any other questions? Any other follow-up questions? Okay.
No, yeah, we'll move to Emily's presentation, and then if anything else comes up, we can still cover some of those questions at the end. So thank you very much, Laura and Emily. Are you ready?
I am ready.
Thank you.
All right. All right, so I assume you can all see my slides?
Yes.
Okay, great. So just to give you a little background, my name is Emily Matillo, and I work for an organization called the Center for Community Solutions, and we're based in...
Emily, we're still showing the note portion of it.
Oh, okay. Let me see. Sorry. Let me switch that. Hold on.
Okay, perfect. Thank you.
I apologize. So we are located in Ohio with offices both in Cleveland and Columbus, and we consider ourselves a nonpartisan think tank with an applied research team, and that's the area I work is on our research team. We're often hired by Ohio nonprofits and government agencies to assist them with things like survey design, data collection, analysis, and data visualization projects. And we accept these opportunities if they relate to the priorities we're interested in as an organization. And one of those priorities is the well-being of older adults. So we're often working in collaboration with other agencies to do exploration of the state of older adults at the county level and city level.
One more thing, so, I'm sorry, your control screen is showing.
Oh, okay.
Okay.
Is that good?
Yes, perfect.
It's like I have to get up and walk to it, but okay, should be good. So today I'm going to discuss 3 different projects we've worked on here at Community Solutions that have focused on measuring the well-being of older adults, both at the county and city level. The first project involved developing county profiles specifically for older adult population. The second is an assessment that was completed as part of an age-friendly cities project. And the third is a needs assessment for a county with a particular focus on assessing the need and readiness for long-term care services. Okay, so the first indicator project I'm going to highlight is one we did in collaboration with the Area Office on Aging in Northwestern Ohio. And I just really love the opening page of their website. And so I had to share a screenshot. Rarely do we see images of older adults that are full of energy or humor. And because I know so many older adults are full of energy and humor, I wanted to just highlight this, and really I appreciate it. The Area Office on Aging hired our agency to assist with their strategic planning process. And as part of that process, they wanted to really gain a better understanding of each of the 10 counties that they work with. So in 10 counties, they provide various programs and services that are for older adults and adults with disabilities. The area agency wanted to be able to provide a detailed picture of older adults living in each county, which would then allow them to identify similarities and differences between the counties and among older adults, and then to be able to adjust their programs and services based on those differences. In addition to their staff, the profiles have been shared with stakeholders, including their funders, their volunteers, their county administrators, and some of their other elected officials. The first step in this project was figuring out what to include in the profiles. And we needed to know what they were interested in learning about and what they wanted to communicate to their stakeholders through the county profiles. And it turns out there were a lot of things that they wanted to include in these profiles, so many. But we were able to work with them to narrow it down. Naturally, many of the things they wanted to know didn't really have a good data source, so that sort of helped us narrow things down. And then we just went through and talked through with them what we had data for, what we could sort of create some data for, and then, or create some processes to develop data for, and then also what they were most interested in. So we ended up with profiles that were 6 printed pages each, and they have all the information that we could fit in there. This was our final indicators list. And so many of these indicators, about half of them, we were able to use U.S. Census data, and we provided them tables and charts and different visualizations with that data as it related to older adults. This included education, poverty, employment, housing, grandparent caregiving, race and ethnicity, age range, disability, and the number of households using SNAP. So here's just one example. This is a demographic table we provided, which includes pretty basic information for the specific county, which is Lucas County in the state. And that allowed for them to get a quick comparison between where the county was and where the state was overall. And we included race and ethnicity as well as age range. We also wanted to show the percent of population living with disability within the different age groups. So you can see we have younger adults, starting at 18 all the way up to age 75, just showing how the disability increases with age. This looks blank. Can you? Okay. So we wanted to show participation in the labor force, which was shows how many older adults in the county are employed, unemployed, and not looking for work. And again, we looked at different age groups for this measure. But as you all know, you can't find everything in a census table. So we needed to rely on additional sources. This included using data from the Area Agency on Aging themselves. They have some data they were able to share. We also worked with state departments and in some instances used national studies, such as the National Alliance for Caregiving. We used some HUD data, the State of Senior Hunger in America, and then also a report by New Retirement. Sometimes we have to be creative with our data and create prevalence estimates based on national or state estimates. When we do this as an organization, we always make sure to clearly frame the data as estimates and point out that the data isn't perfect, but it's the best we have at this time. We honestly try to avoid doing this, but sometimes the partner we're working with really feels that it's something that the community needs to know more about. And so if that's the case, and if we agree with them that it is an important data point, then we'll create an estimate, a prevalence estimate. This here is an example of using data that we knew existed, but it wasn't public. And so we went right to the source, which was the Area Agency on Aging we are working with. We wanted to be able to demonstrate how many older adults in each county were participating in local programs, namely senior center programming and congregate meal sites. These programs are both federally funded through the Older Americans Act, and therefore we knew they required reporting by the area agency or whoever the service provider was, and they would have to report to the area agency. So we knew the data existed. We just had to help the area agency figure out how they could share it with us in a way that did not compromise any of their client confidentiality agreements. And so once we did that, we figured that out, and then we were able to make the data they already had and to use it in a way that helps them tell their story about how many older adults in their community were visiting senior centers and how many were accessing meal sites. And by mapping it, we can see that there is the southern part of the county that really doesn't have a senior center. The area agency we were working with was also really interested in the prevalence of elder abuse and the type of elder abuse being experienced by older adults in their community. In Ohio, we have reporting and responding to elder abuse is done at the county level, but we did not have consistent access to the county level data from each of the 10 counties that we are creating profiles for. Recently, our state implemented a new data tracking that is statewide, but some of the counties were better at using it and getting data out than others. And so rather than have different types of data from different counties, we went to the state and were able to use a fact sheet that they published about adult protective services. And that fact sheet includes data that is done at the state level. We then used U.S. Census population data and the state fact sheet to estimate prevalence of abuse in each county. We did feel comfortable with using an estimate here because we knew that most elder abuse goes unreported, and we felt confident that if anything, we would be providing an underestimate of actual abuse. We also included the state level distribution of incidences of elder abuse reported in 4 categories. You can see that it's abuse, self-neglect, neglect by others, and exploitation. And you can see in our source notes where I've highlighted there that, that this is an estimate, so we always try and make that really clear. The area agency is really interested in caregiving. This is an area in their strategic plan that they really want to focus on, so they were really wanted to have some data in their profiles about caregiving, but unfortunately, this is not something we could find at a state or county level. Caregiving data in general is hard to come by because it's hard to quantify, and many people who meet the definition of caregiver do not really consider themselves caregivers and don't self-report that way. Because the area agency really wanted to include the data on caregiving, we did use a national study done by the National Alliance for Caregiving and AARP, and we highlighted the amount of time, which is 24 hours per week, and money, which is $5,000 per year, that the average family caregiver spends. At this point, this is really the best data we have, and for the area agency, learning that there was nothing more local than the national data actually prompted them to start thinking about how they can start collecting data for their own community, and they started developing some tools so that the next time they're doing their strategic plan, they'll be able to pull some of their own data. Now I'm going to shift and talk about the work we did with the City of Cleveland on their Age-Friendly Cleveland assessment. For those who are not familiar, the Age-Friendly Cities model was created by the World Health Organization and then quickly adopted by AARP as the affiliate in the United States. Cities who are interested in receiving the Age-Friendly certification agree to engage in a 5-year cycle. And that first year includes an assessment of age friendliness, which also includes identifying indicators. As with the county profiles, some of the indicators that we ended up using for this project come from the U.S. Census data. The remaining indicators are guided by the 8 domains of age friendliness, which are part of the existing model here. So we started with a demographic profile that is similar, honestly, to most of the older adult indicator projects we work on. And I have the list here. Unless otherwise noted, we are looking at these indicators by city. Many of these come from census data. However, sometimes we needed data smaller than city. Oftentimes, in Cleveland at least, we want to know things by ward or by neighborhood because that's how older adults identify themselves. It's also how city funding works sometimes. We have, each of our wards has their own council person. And so we have a lot of, I don't know, just our council people want to know things about their wards. So it's how we look at data often. But City of Cleveland wards do not line up with census tracts, as I'm pretty sure that's true in other cities. And so we've developed a partnership with a local university who developed a methodology for analyzing census data, both by ward and by neighborhood, which has slightly different boundaries in Cleveland. Our partner developed an algorithm to split and reallocate block groups into other geographies, into our smaller geographies. It also recalculates the margin of error. And honestly, we often subcontract with them when we have a need to do these smaller geographies because we can find that it's really useful to have. So for instance, here is an example of when we use the smaller non-census tract geographies. Here, it's this is the city outline of the City of Cleveland, and it's divided up into the 17 wards. And this was really helpful because indicators at the ward level were needed to help the city determine where specifically they wanted to target their programming. Knowing where within the city had the highest rates of poverty and the highest rates of older adults living alone was useful information for the city as they considered where they were going to launch some of their pilot programming. And here you can see that Ward 5 is clearly jumps out as an area of focus for their initial efforts. The age-friendly model requires assessing the city's age friendliness along the 8 different domains, and these are outdoor spaces and buildings, transportation, housing, social participation, respect and social inclusion, civic participation and employment, communication and information, and community support and health services. We needed to develop indicators for each of these domains to measure the age friendliness as they're perceived by older adults who are actually living in the community. For instance, there was no existing indicator that we could find that would provide a measurement of how people in the city or how older adults in the city usually travel, whether it's by bus or by car or by walking, nor could we find anything about the availability of timed crosswalks in different neighborhoods. And so we knew we needed to survey the community. So we used survey questions from previous age-friendly assessments, and then we also worked closely with an age-friendly advisory council, which consisted of some subject matter experts, and also received guidance from older adults living in the community on what the question should be. Our survey ended up having about 10 to 12 questions on each domain. And we used voter registration to draw a random sample of older adults in the city. And our return rate was high enough to generalize to the larger community, which was fantastic. So I just thought I'd show you one domain example and some of the data that we collected. So we asked in the survey, what is your usual way of traveling to appointments, errands, events, or community locations? And we analyzed this by age. So you can see we have two categories here. We have younger older adults. They were between the ages of 60 and 74. And then our older adults, which are 75 and older. And then you can see the difference between the two age groups is most pronounced in the drive myself. More younger older adults are doing that. And then more older adults are being driven by their friends and family. We also needed to know about traffic safety features in the community and the ease of access to transportation for Cleveland older adults. So we asked things about traffic signs, the ease and access of public transportation. Parking is always a big issue in the city here, and so we wanted to ask questions about whether or not people had places to park. We also wanted to know about pedestrian crossings. And then one of the issues that actually came up from our older adults who guided us was to find out if there were driver education or refresher courses in the area. So for people who were in their 60s, 70s, 80s, 90s and thinking about whether or not they should still be driving, was there an opportunity to go through a refresher training or a way to determine if they were still ready or able to drive safely? Finally, we wanted to know about older adults' behaviors and perceptions of transportation-related features of the city. So we asked if they had challenges when traveling to the things that they do in their lives, appointments, events, communities, locations, etc. And so we asked if they had problems getting around, if they drive, if they have a car, if they can afford a car, if they have problems parking. So similar to some of the other questions, but asked in a slightly different way. This survey allowed us to have very specific indicators related to transportation that we were not going to be able to find anywhere else. In the 5th year of the age-friendly model, the assessment happens again to measure improvements following the implementation phase. So Cleveland, for instance, is on their 4th year. So next year, they should be using the same survey again and measuring whether or not there's been improvement based on some of the age-friendly programs they've implemented. And so in theory, too, this creates some ongoing localized measurement of senior well-being. Now, you may not be super interested in Cleveland, but good news, there are many other communities in the United States that have adopted this model. So there are currently 6 states, 1 territory, and 440 communities, and those could be cities or counties, that have joined the AARP Age-Friendly Network. So if you go to the AARP's website and search for age-friendly communities, they have a member page. And on that member page, you can see when the community joined, where they are in the process, and sometimes there'll be a link to their action plan or their assessment or their survey. But for all of them, there is contact information. So if you are looking for very specific data about older adults, in one of these communities, in one of these domain areas, I think it's definitely worth reaching out to whoever the coordinator is to see if they're willing to share it. All right, so the next and final project I'll discuss is the work we did with an area agency on aging. This is a different area agency on aging, to conduct a needs assessment for one of the 5 counties they provide services for. And just to give a little background on this project, I will share that Ohio is a little weird in how we fund some things. We are one of the few states that have tax levies, and the levies can be on both property and sales, that fund senior services. And some of those levy funds subsidize in-home care services and supports. So currently we have 74 out of our 88 counties that with such levies. So that means there's just a handful that do not have levies, and generally they have reduced senior services offered in those communities. So the county we were asked to assess needs is one of those counties that doesn't have a senior levy, and they really wanted to have some local data and analysis to be able to determine if a levy would be justified, if they would be able to go to their elected officials, to the community, and be able to argue for a levy. So one of the things they were most interested in knowing was how many older adults were not going to be able to afford long-term care. They wanted to be able to begin educating the community about the challenges many older adults were going to face in being able to pay and access long-term care. We couldn't find any existing indicators that really answered or demonstrated these questions, and so we developed a model to estimate the number of those older adults who we thought might be at risk. So when we were thinking about affording long-term care, we decided to group the population into 3 categories. Those who are likely eligible for Medicaid, and those are people whose income is below $25,000. Those who are likely able to private pay, and we believe that those are people whose income is above $60,000 a year. And then those who are likely ineligible for Medicaid and also likely unable to private pay. So those are people whose incomes are between the $25,000 and $60,000. This group that is in the middle, that's not likely to qualify or private pay, is a concern for many communities. Often this group relies heavily on family and friend caregivers if they have those people in their lives, and oftentimes they actually receive less than the recommended level of support and are at risk for increased hospitalizations. So we wanted to know how many people in this county fell into each of those categories. So we're able to use U.S. Census data for household income for older adults living in the county to provide an estimate of how many older adults were in each category. We found that 38% would be likely eligible for Medicaid, 29% would likely be able to private pay, and 33% we believe are at risk of not being able to access long-term care services. So in addition to knowing how many people would potentially be at risk for not being able to access the services, we also wanted to know if older adults were thinking about the future long-term care services and getting prepared. So this project involved both a phone and paper survey as well. And one of the questions we asked was, how concerned are you about being able to afford the services you may need as you age? For survey respondents who self-reported their income as between $25,000 and $60,000, we found that 57% were not really all that concerned about being able to afford long-term care. And based on the other questions we asked in the survey, it became clear that there is a lack of understanding about who pays for long-term care services and really just how expensive it can be. We found many of the older adults mistakenly believe Medicare will be paying for long-term care services. And to be clear, and I say this every chance I get, Medicare does not pay for long-term care services. And so based on some of the survey questions and this question, we concluded that those who are not concerned about being able to afford long-term care were also not likely to be preparing themselves for long-term care. So from our analysis, we were able to provide the area agency with this one-page infographic to help them communicate their concerns about the preparedness of the community in relation to long-term care. We found 1 in 3 older adults in the county may be at risk of not being able to access the care, and 57% are not likely to be prepared. Okay, and so with that, I hope I've given you some good examples of what measuring senior well-being looks like at a local level, and how we achieved that in 3 different projects. And I'm happy to take any questions.
Great. Thank you very much, Emily, for a very informative presentation. Probably the first question I have is relates to something that actually links those 2 presentations together, where we social isolation in the built environment are obviously very linked. If you cannot get to anywhere, you obviously will increase your isolation. So I did see some very dire numbers from Laura, and then on social isolation, and some not very encouraging numbers on transportation, how transportation needs were met from Emily. And I'm wondering to what extent any of that, and a lot of it, of course, was focused on cars, since that's usually the main mean of transportation in most places. But I'm wondering if this has led to any recognition of any alternative ways of transportation besides car, with the recognition that the ability to drive obviously will be decreasing with age.
So from our perspective in Cleveland, when we were doing the age-friendly project, we were pleased to find that many older adults were familiar with bus routes and comfortable using them. One of the big challenges in our system is that about a year before we did this assessment, our bus routes changed and reduced, and stops became further apart from each other. And so that we found was a really big barrier for older adults. If they had to walk more than 2 blocks, sometimes they just couldn't physically do that, particularly in the winters here. And so when that was the case, they talked a lot about not being able to go to church, visit their friends, go to the library. They just were choosing to stay home instead. And so what they really were asking for was like a door-to-door service that would allow them more flexibility and more ways to connect socially with people. And we have a little bit of that here, but I think it's going to be a growing need throughout the country.
Laura, can you say anything about how transportation fits into that issue of social isolation?
Well, I think it's a very relevant measure for risk of social isolation. We've actually been in pursuit of a transportation-related measure that we could include as a separate measure in our report for seniors, as well as something related to housing, and we've had some difficulty finding that. I did reach out to Emily prior to this call, and she had shared just a data source from using census data about just availability of a car at all for seniors. I'm not sure how well that would capture the issue, just because a lot of seniors are also using public transportation. And so it's one of those issues where we're just kind of lacking a good, reliable data source at the state level, or that's available in all 50 states.
Right. In Laura, you actually, Emily spoke quite a bit about the sources of the data, including the surveys that were conducted locally. Can you expand a little bit on the source of I think you covered that very briefly on your presentation, but did you have to do any primary data collection for the the health ranking?
No, we use all secondary data sources for the health rankings. We're a super small group, and so we don't really have the budget to do primary data collection on a regular basis. So we really use survey data, American Community Survey, which is part of the census. We use that's our data source for the risk of social isolation measure. All of our factors are from that data source. They're just found in different tables. And then other than that, we use a lot of data from the behavioral risk factor surveillance system. That's a survey that's designed to generate state level estimates. And then we use national vital statistics data, like mortality data. And then we also use, I think Emily mentioned, and now I'm just blanking on it, but our source of data for food insecurity is a report that comes out every year that provides that data for us. And so we have a really wide variety of sources. Our biggest limitation is we just need to have the data updated kind of either annually or every other year, and we need it available for all 50 states. So,
and of course broken down by age.
And of course the age breakdown, and that's where we're running into some limitations with housing related measures. But I did take notes on the measure that Emily brought up about elder abuse, because we have been looking for something related to that.
Okay. So the question, have either of the speakers found ways to incorporate measures of individual or community level social capital? It seems like you covered some of them, but anything to add to that?
I don't know that we have found any that I haven't mentioned. So I don't think I have anything to add. I apologize.
I don't think I have anything to add either. I was just, I can't think of anything off the top of my head that we found. But if the audience has suggestions.
Yeah, it's actually interesting because that brings up one question that, so a lot of the measures, and that is very common in our field, are deficit related questions, deficit related indicators. Can you think of any, what is the opposite of a deficit indicator? A positive indicator that is being tracked by either one of you?
So through some of the age-friendly assessments, and the age-friendly assessments are not standardized over all the communities, but many of them ask pretty similar questions. But within the age-friendly assessments, there are some non-deficit based things, especially in like the respect and social inclusion domains and the employment and civic participation. Nothing's like jumping immediately to mind, but I do know those were a little bit more positive and thinking about what older adults can contribute and how valued they feel in society.
Did you have anything to add to that, Laura?
So I think most of our measures are measuring something that is more, negative in scope. However, we do have we do measure, now that I'm looking at it, so volunteerism, and there's a measure of community support that we include, which is expenditures captured by the Administration on Aging per adult age 60 and older living in poverty. We also have a measure of able-bodied, which I believe is kind of the opposite
Right.
of living with a disability. It's, you know, percentage of adults with no cognitive, visual, auditory, ambulatory self-care or independent living difficulties. So we do have that as a separate outcome in our reports. And then high health status is the self-report of having very good or excellent health. And that's in all of our reports.
And I forgot when you mentioned volunteering, were you mentioning it in regards to having the general population volunteering to help older adults, or were you looking at volunteerism rate within the older adult population?
So it's actually the percentage of older adults who reported volunteering in the past year. It's a measure that we get from the Corporation for National and Community Service.
Mm-hmm. Okay. Do you have any questions of each other?
I just want to say I'm excited to dig into some of Laura's work on social isolation. It's hard to say. We have been thinking just as many other organizations have been thinking about it. We've been thinking about it more at Community Solutions here, and had not really explored the index that they use. And so I will probably be making a request for that zip code and census tract level of data.
That's great.
Excellent.
I'll probably be reaching out to you with maybe questions about indicators for seniors going forward. So I really appreciated hearing about what you do.
Well, wonderful. Thank you very much, both of you. I learned a lot from those presentations. I will probably reach out to both of you with more questions after this. I want to thank both of you for taking the time to put your presentations together and speak to us this morning. And to the audience, I hope you had all your question answers and this met your needs. And I look forward to seeing you, quote unquote, at future webinars. So our time is up. Thank you very much and goodbye.